First, I want to say thank you for all of you that are tuning in, and hope you get some really good, valuable information that you can take out and be able to use with your athletes. So let me get started. I want to first just let everybody know this is a typically a much longer seminar. I typically have anywhere from an hour to 2 hours that I do this seminar with. So this is a condensed version. But my goal is to try to still provide you some very valuable information that you can take and be able to use and apply. So just kind of quick review. It may be a review, maybe new information. I don't know, depending on what the backgrounds of each of you are. But just a quick anatomy review. You've got the components of the knee where you have the femur up above, and then you have the tibia and fibula down below with the kneecap right there on top. And then your ligament structure around the knee, you have your medial collateral ligament, you have your lateral collateral ligament, your PCL, and then your ACL is right there in the front. And so the whole purpose behind it, you have your medial and lateral collateral ligament that are there to provide lateral stability to the knee, or what we call frontal plane stability for the knee. And then your ACL and PCL are meant to provide stability in the anterior and posterior plane. And then your overall, what that does is that provides passive restraint for the knee. And then our active restraint is going to be our muscle control, which primarily, if you look at all the overlapping muscles, we have a lot of overlap around the knee between the quadriceps, the hamstrings, and then you have the gastroc-soleus, the popliteus muscle, all those that come around the knee and help provide stability from an active control standpoint. And it's going to be a combination of neuromuscular timing between eccentric and concentric contractions during movement that allow for the knee to remain stable. So let's talk about one of the main, there's a couple different mechanisms that are involved with the knee. And one of the things that prompted me to go back and really break this down and look at it more closely, this has been a number of years now, but my oldest son, he's almost 30 now. So, but his freshman year of high school, was playing football, managed to split two offensive linemen. He was a linebacker, had the running back stumble, crashed through his knee, tore his ACL. So that was a pretty obvious mechanism as to what happened there. Well, fast forward, we ended up getting his knee repaired, and he wanted to continue to play. So we got knee braces, and he played with knee braces all through high school. And we got to the last practice of the last regular season game, and he decided to try to jump up and bat a ball down. And when he came down straight-legged on the same knee and snapped the ACL on his same knee. And so it made me really go back to the drawing board of what the mechanisms were, why that happened. And again, that was back when I was a coach and I was still practicing as well, and actually really early on in practice. So I really needed to go back and look at the mechanisms of the knee. So when we talk about the knee screw home rotation, there's a couple different terms that we need to make sure we're all on the same page with. One is an open chain. So the open chain is any movement that is not in contact with the ground. So we have different mechanisms between the femur and the tibia. The upper and lower leg determines, the amount of rotation and twist and those things that we get. Versus a closed chain, which is contact with the ground. So when we talk about the knee screw home technique, what we're talking about is in the last 30 degrees that knee starts to straighten out, you're going to have a 10-degree rotation. So if you're in a closed chain, the tibia is going to rotate externally about 10 degrees. And if you're in an open chain, the femur is going to internally rotate about 10 degrees when it goes into full extension. And there's a couple reasons for that. One has to do with the medial slope of there's a slope to the medial condyle. It has about a 30-degree slope to it that's going to facilitate that. Then you also have the contraction of the quadriceps muscle. So if you look at the bulk of the muscle is on the lateral aspect, and it comes down, wraps around the patella, and attaches to that femur. And so it causes that knee to rotate, externally. And then you can also go into what we call a little bit of a hyperextension, depending on the degree of quad dominance that you have. And I'll touch a little bit more on that here later. The other important component with this too is that the popliteus muscle that's on the back side of the knee is responsible for unlocking. And when it unlocks, it reverses that rotational component to allow the knee to go back into flexion. So looking at the different groups, so you have risk of injury, your competitive versus recreational athletes. Females are 9 times greater, high school females are 9 times greater at risk of tearing an ACL of non-contact than a male will. The age range is anywhere from 15 to 25, which kind of falls into our range of when most of us are most athletic and out there really pushing ourselves and going hard. And then as far as your non-contact, your non-contact is 80% of your ACL injuries versus your contact. And so what that means for us, though, is that with that 80% outside of some anatomical variations, which I'll get into that a little bit, you have the ability to be able to modify and be able to have an impact and affect that, to be able to reduce the number of incidents and the level of risk that we have with that. So again, females versus males, you're going to have females that have a higher propensity to tear their ACLs non-contact, and as they move up, it's 9 times greater for high school athletes. It's 5% greater chance of tearing an ACL once they hit college and pro. So the risk level doesn't minimize just as they get higher as far as male versus female. And then when we talk about, sports with the highest dynamic loading, it was kind of interesting when I looked at it. Some of them made sense, and then there was one that was in the top 4 category that didn't make a whole lot of sense to me. But it's basketball, volleyball, soccer, and then handball. And so I'm kind of old, so my thought of what handball was, I'm thinking of like the little half court deal that you had in the gym with the little blue ball, and you could play racquetball or you could play handball in there. That's not it. And apparently it's fairly common up north. We do not have that down here in the South. But it involves a court, and you have baskets and things like that. And it requires a lot of dynamic loading that's very similar to what you would see with basketball. So that was quite interesting to see. And then as far as military personnel are concerned, there's not a whole lot of data that supports that a female would tear their ACLs faster, but a lot of that has to do with roles. Now, as we have started to see females take on a more combat-related role in the military, then we expect to see those numbers to change. Okay, so consequences of injury. Most of you already know these things. Somebody tears an ACL, now you've lost play time, you get recovery time. There's a possibility with some athletes that may not ever return back to play. So those are issues. Military, same thing, your loss of duty time, possibly medical discharge, depending on the severity of the injury. Now, if you have a prior injury, once you have torn an ACL, or if you have injuries such as a meniscus tear, okay, or any other ligament tear, you have now induced further instability into that knee, which is going to increase the likelihood of an ACL tear. Re-injury, males are a lot more likely to re-tear an ACL. Now, one of the things that we will talk about is if somebody tears an ACL on one side, gets it repaired, and then tears the ACL on the other side. That's a little different animal that we're talking about there, and I'll talk about that here in a few minutes. And then the long-term effects, they're showing that 84% of people that have had to have surgeries have had some sort of patelloosteochondral effects long-term that they've had to deal with. So there's 4 main structural features. Now, these are things this is the way the body is designed, the way the body is built. And everybody's different. There is a little bit of a genetic component to it to a certain degree, and I'll give you an example of that. So we get into the intercondylar knot size. What we're referring to that space right here between these 2 condyles in the knee. And if you have a smaller size with that, which can be typically common with females. What it does is it decreases the amount of space that we have to allow that ACL to stretch during dynamic loading. So the only way that you can really diagnose this is if somebody has x-rays done and somebody actually goes through and does a measurement. But the telltale sign of it is if they tear an ACL on one side, and then after they've gotten recovered from that, they not too long after that tear the ACL on the other side. Now, I did have an incident where I had a coach contact me and said, "Hey, I attended your class on the ACL tear," and he said, "Is it possible that it's genetic?" And I was like, "Well, give me a little bit of clarification of what you mean by genetic." He said, "Well, the older sister had torn both of her ACLs, just like I had described. And then apparently both of her younger siblings tore their ACLs in the same manner." And so what that tells me is there was some sort of genetic component there that was passed down. And I'm sure that if they had gone back and checked either mom or dad's anatomical structure, they probably would have seen that they had a narrow intercondylar knot size as well. So there's that. Okay, the integrity of the meniscus. And when we look at the meniscus there, once you tear it, it is designed to provide a tracking mechanism as that knee goes into flexion and an extension. And if you disrupt that tracking mechanism within and that glide that you have, then it is going to affect the stability and the way stress is distributed throughout the knee. So when we talked about your eccentric and concentric muscle contractions, as you start to slow down, for example, stress is going to travel. You have your driving mechanism that comes out of the glute, goes down through the leg, and then the forces will transmit into the knee. If you are using proper muscle contraction, it should go from an outside in. If we don't have proper muscle contraction to be able to slow down and be able to have good braking mechanisms, that stress transmission will go from inside out. So it's extremely important that we maintain integrity of that meniscus whenever possible. But we have to know if they've torn their meniscus at any point in time, they have now increased the risk that they could potentially tear their ACL. Then you have the joint capsule itself, which all the way around it. So you have these main ligaments here, but then you have a capsule around it, and that helps provide the rest of the passive constraint that we have for the knee. So if you have any damage to that capsule as well, that's also going to affect the stability and increase the risk that somebody has for tearing their ACL. Now, tibial slope. This is again, from a coach's standpoint, this is not anything that we can necessarily, go out and find. If I have trainers on here, you might have more of an interest in this. But if you do an X-ray on somebody, we draw a line that runs right down the femur, or I'm sorry, the tibia there, and then we draw a line straight across where the tibial plateau is, and we check the angle of the plateau with the crest. And so if that angle is more than 30 degrees, then that player is at a higher risk of being able to tear their ACL. And this is just research that has gone into some of these anatomical variations that are contributing factors. It's not necessarily things that we can affect on the coaching side, but hopefully, we can be able to work with our trainers and our staff to be able to facilitate, better understanding and be able to watch our players a little better. So your dynamic and modifiable biomechanical features. So you have your main stressors of the ACL. Again, we're talking about dynamic loading and the amount of stress and the forces that are generated through the knee. And so, proper alignment, knee alignment during movements is extremely important. The most common mechanism is any type of mechanism that's going to cause the knee to go into what we call valgus, which means the femur, the upper part of the leg is going to go in, and the lower part of the leg has an appearance that it is going out. So we have that, it could be into a hyperextension. It could also just be from that knee, looking like it caves in. So, and then we have the effects of quad dominance. I have a whole entire seminar that I do just on squat, and we talk about quad dominance and the effects that it has on the pelvis and the low back and hamstrings and all those things. But just from this standpoint, when the quads are extremely tight, it's going to take that lower leg and it's going to pull it forward whenever that knee goes into a locked out position, and it's going to put it into a hyperextended position just because of the quad dominance. And so that's going to increase the risk of tearing an ACL with that. It's going to put more stress and strain on that ACL inside the knee. Also, poor muscle control. Muscle control is not just in the legs. We're also talking about core muscle control, being able to control braking and stopping and redirecting, being able to use our core. You know, I touched on that quite a bit in the previous webinars that I've done, talking about speed and agility and using our core and the importance of core control to be able to control movements, especially when we're talking about, you know, center of mass. And then our frontal plane motion, what we're talking about is that motion from side to side. You know, you think about somebody, if they try to stop and their legs are trying to stop and dig in, but the upper body's carrying over, that's poor muscle control, especially in the core. So those are things that we need to work on. So when we talk about frontal plane motion, this is somebody, they just had her do a simple drop box test. So they have her jump down, she lands, they managed to catch it on motion camera, and then we look at the angle of the knees as they collapse. This one, she looks like she's kind of flat-footed as well. So typically I don't test people barefooted, especially if they have flat feet, because you're going to pick out problems that you can't necessarily fix with that. And most of the time, if they have shoes, they're aware that they have flat feet, and they're going to wear shoes, they're going to compensate for that. So you always want to do your testing with whatever shoes they normally wear, unless we're talking about cleats or, you know, even in extreme cases like ice skates or things like that. Just have them wear a decent pair of athletic shoes that they normally work out in. Now, some people will get into what we call the Q angle. The Q angle has to do with the angle of the hips, and the females traditionally will have a higher Q angle than males will, as far as their ability to be able to square their hips out a little better. But you can still train females to be able to have the same proper hip alignment during movements. And so I don't necessarily think that that's a major factor, because you can retrain that, and you can get the muscles to be able to help realign those areas. So now, some things that we need to consider as well is fatigue, especially if you have certain sports like basketball and things that require a lot more endurance. Fatigue is a big problem, and as fatigue starts to set in, we're going to lose more and more motor control. We're going to lose technique. We're going to become less concerned about those things, and we tend to start playing a lot sloppier. And then I'll show you some video example of that here in a few minutes. We have core and trunk stability. Again, that's that being able to control that frontal plane motion, and being able to control starting and stopping using their core. And then lateral hip displacement when we talk about squat. So we're talking about, if somebody goes down into a squat, do they have a shift over to one side or the other? And that's going to have some effects on stability. It's going to have effects on strength, and it can also have some effects on being able to take off and land with some of your jumping type sports. So, and I'll show you some examples of that. So here's an example. You have this young man here. He's got very, very quick, very sharp movements, very crisp. He's chopping his feet. Really, really good technique. So we're right here at the beginning of the game. And then as we get into the second quarter, we're still moving pretty well. Fatigue has not become a significant factor yet. We still have, some landing stuff. I could do a little bit better on the landing right there, but he's still in good position. So when we get into the third quarter, now we got more fatigue. We're losing control, getting sloppy. We're not popping our feet like we were. We're just kind of stopping and drifting, and then watch as he gets to the fourth quarter. All those crisp movements that you saw at the very beginning of the game, they're not there anymore. So right now he is at his highest level of risk of being able to tear an ACL, just from the fatigue that has set in. So, when we talk about core control, watch when she stops right here. Notice that little tilt that she does right there at the end. That's a core control issue. That's that frontal plane that we talked about, and we've got to learn to engage our core more to be able to help with our stops and redirects. Now, this young lady, watch her hips when she unlocks. If you notice, she has a shift to the right, her right, our left, and that's one of the things that we're looking for. When I look at squat, I always look at it from two different planes. Well, when it cycles back around to the other plane, watch it again. Watch her hips unlock, and she has a pretty clear shift right there. Okay. Now I'm going to show you what that affects when she gets into jumping. All right. So when we get into our functional assessment for potential ACL risk, so I'm going to look at the back squat. I'm going to look to see, I have some good examples, bad examples through here. Can they get down to parallel? What's their upper body doing? Do they have good extension when they get down into their squat? Do their heels remain in contact with the ground, which they should? Okay, if they don't, it is a poor ankle mobility issue. So this is somebody that she's got a little bit better squat. She still unlocks and drifts to the left just a little bit, but not as bad as some of the other ones that I've seen. Y balance, there's not a lot of people that have used this. I really love using this because it gives me a quadrant. We have both upper and both lower quadrants, and it gives me an efficiency, a movement efficiency for each side. And I've used this with veteran groups that I've worked with, as well as athletes and first responders. And it really gives us a good idea of what their movement symmetry is like from one side to the other, as well as the efficiency. Okay, then you have your drop jump screening test. So we have, now this is the same young lady. I want you to watch what happens when she lands and takes off. She's going to drift. She drifted to the left. Okay. So again, when she squatted, everything shifted to her right. So we've developed a significant amount of dominance. Well, what does that affect when we start trying to jump? We get more push from one side to the other. So now we're drifting at angles instead of straight up and down. Okay. Okay, so you have your single leg vertical jump assessment. With this one, I always do a balance assessment first. I'm going to see, what is their hip alignment like? What is their core stability like? I'm also going to watch that knee. They should be able to keep that knee squared out, or does it drift over towards the middle? So just like anything else, anytime we have weakness or we have something that we're trying to compensate for, we turn the draw towards the midline of the body rather than being able to keep it squared out. So those are things that I look for first before I do any type of jump assessment. Okay. And if you know, she brings that leg right up, she's holding it, she's stable, and she's squared out. Okay. Now, when I do a jump assessment, now I'm going to look and see, I'm looking to see, do they land straight legged? Do they have a significant amount of valgus in that knee when they land? Okay. So a little bit of instability there. Okay, and a lot of these things are going to be carried over from things that we're going to see, in the other assessment portions that we do to determine their level of risk. Okay. Okay. So then we get into our single leg motion analysis, sidestep cutting maneuvers. It's simple as like a pro shuttle. Watch when she plants on this side. Look at that leg. That leg is tilted in. She's overextending. Okay. Right there. Okay. So this young lady is at a pretty significant level of risk for being able to tear her ACL. Okay. I'm going to kind of bump through these because I know we're getting short on time. Saxon, please feel free to just jump in and cut me off if you need to. I'm also looking at here, motor control. Look at her knees. Her knees are bowing in instead of staying squared out, keeping balance, keeping alignment between the shoulder, hip, and knee. Okay. So those are things we've got to be really, really picky about technique. And that's what a lot of this is being more picky about our technique and not just allowing things to slide. Okay. Got good redirection. She stays squared out. She stays balanced all the way through. Okay. So the importance of having an ACL program, and it's not something you have to have something completely separate. You can incorporate this in. And some of the exercises that people do, they're already doing the exercises. The problem is what their focus is, and that they don't harp on the technique that comes with it as far as why they're having them do that particular exercise. So when we get into an ACL program, you have 6 principles that we've got to look at. One is age. The younger the better. All right, as soon as they can start comprehending what you're telling them, start working on technique. And that's one of the biggest problems that we have, especially as high school coaches, is we get these athletes that have come up into the high school program, and all they've ever learned is just schemes, and nobody's ever really taught them technique, when what we really need is for them to learn the technique, and then we can focus on teaching them schemes. And it's always backwards. We have people coming up with all these concepts of what schemes are, but then we're having to teach the technique. So biomechanics, extremely important to be able to assess somebody's biomechanics and look at how they're moving. And then compliance rate, if you have 66% compliance for a program for each athlete, you're going to reduce the ACL risk by 82%. So that's a pretty significant deal, just getting them to do what you're supposed to do, and following and obeying the techniques that you're talking about, and following with your coaching. So dosage, you're looking at about 20 to 30 minutes, about 3 to 4 times a week. All right. And again, that's just incorporating it. And you should have different phases in your off-season program. So you should be incorporating these things into your different phases, making sure you're giving good feedback. Don't let them slide on technique issues. If you can video their movements and their techniques on things that they're doing so that you can point those things out, that's really, really important for them to be able to see those things. And as far as your exercise variety, you have 3 components of your training that you need to do. You have to have plyometrics, you got to have neuromuscular training for balance, and then strength training is extremely important. So, so let's talk about a training progression, and how you put this together. So you want to have it where once you get a baseline of where everybody's at, where your athletes are at, then you can kind of decide what exercises that you want to starting off with, and then how to progress from there. So this is just an example of one that I put together for a group. So we started off, this was our tier 1. So this was where we started. So our focus with this is that we need to do quite a bit of neuromuscular re-education. People that have had injuries, they're going to have abnormal weight shifts, and then they will stay in that permanent shift until somebody goes back and retrains them to get back balanced again from one side to the other. And I mean, I've had people come through that, they've had the same injury. They had the injury 10, 15, 20 years ago, and they still have the same compensation. Nobody ever taught them that they needed to go back and correct those things. So this is kind of an example of a tier 1 that I would do with somebody, in the dosage that I would give for that one. Okay. And so your progression, these are your main focus areas. You want single leg exercises, lateral stability, increasing your range of motion and mobility, posterior chain stability is really important. And they're working on your core and diaphragmatic type breathing. Breathing is extremely important, teaching people how to properly breathe. I always start off with that, and then we progress with our levels of difficulty with core. Okay. So this would be a tier 2. So again, we're increasing the level of difficulty. Okay. And then so with this, we're focusing on more hops and jumps, and our mechanics as far as that's concerned, and proper body alignment, weight distribution, posterior chain strength again, lateral stability, thoracic mobility. So being able to have some movement in through the mid back, and being able to rotate and have that stability. And then your core strength. So after we've achieved some stability, we want to progress to strength where our core is concerned. And then this would be a tier 3. So now we're building up, we're increasing the level of difficulty. And again, this is just an example of one that I put together for a group. So if you notice, there's not quite as much on there, but it's because we're also incorporating other things into our workout program. So this is just part of our initial warm-up type program. before we get into, as we phase into these different things, then we're getting into more sport specific type drills and things like that. So, so this is just a progression. Your phase 3, we're going to do more sport functional drills, agility drills, start getting posterior chain strength, working on agility, which is our redirection, and then core strength as well. We're always going to maintain core, continue to work core. Okay. And that's just an example of, of almost all my kids in there. So, of course, I got to brag on my daughter. She's a little beast. She's got 2 national titles and a state title in powerlifting. So, so I'm always proud of her. But so that's everything with that. If anybody ever has any questions, I know BSN Sports is good about posting my information, and people can be able to reach out to me.